So first of all, let's have a think about what we do when a patient walks in and we're looking for specific tests to help us with our diagnosis, whether it's to rule in or rule out the condition. So when we looked at this, the clinical diagnostic aspects of these particular tests, we found that 4 were the most useful in the diagnosis of this condition. So the first 3 help us to rule in the condition, so they have higher specificity. And the 4th one, palpation of the greater trochanter, that actually is the most sensitive test. So it really means if you're performing this test and the patient does not report any reproduction of their symptoms, it gives us an indication that this condition should be ruled out. And so the combination of this group of testing will help in the diagnosis of an individual with greater trochanteric pain. And as Rachael said earlier, really thinking about the population that you're dealing with. So although it can happen in a spectrum of ages, we really need to be thinking, is this person postmenopausal and are they female, as an easy start to our assessment, and then we can move further into the specific diagnostic tests. So let's have a look at these on video now. So let's have a look at the first one. All right, so our first test is external derotation. Moving the leg up into 90 degrees of hip flexion, full external rotation, slightly taking the pressure off, and then asking the patient to resist back to neutral, hence resisting that external rotation. So you're derotating, moving into internal rotation. It's a bit of a confusing name really, isn't it?
It is.
All right, our second diagnostic test that has high specificity and is useful in the diagnosis is Faber.
Modified.
Ooh, apologies,
Yeah.
This one's the modified version of external derotation. So the interesting thing about this is that it actually adds a deduction, so an adduction component. The usefulness of this is that it actually adds a static compression. So we find that some individuals are actually quite responsive in a negative way, I guess, to that compression component as opposed to the dynamic component of the test. So historically, the external derotation test was that dynamic movement, and then there was a modified version released, which does have that adduction component. So we find clinically that some people are more responsive to the compression versus some that tensile loading with the dynamic part of it. And then equally, some are really painful with both.
That's right. And I suppose just on top of what you've said, Charlotte, you might find that some patients, they're clear or negative when you're doing just the standard external derotation test, but when you do add them into that element of adduction, doing the modified external derotation, then they may be positive, so that helps give you a little bit more information as well. If you're trying to get those answers for your diagnosis and so far it's clear, adding that element of adduction, as Charlotte said, some patients are a little bit more responsive to that.
It's a perfect one too if their aggravating factor is crossing their legs, like
we're
doing at the moment. It's something that we would try and avoid, but it certainly can be an aggravating factor that you pick up in this subjective, and you're then putting the leg into that same aggravating position. So moving on to our next test, we're moving into Faber. So the most important thing with Faber is that it can be used for so many hip pathologies or sacroiliac joint presentations. So we have to be really careful about how we implement this test. It's the same procedure as you would do if you were looking for pain in different areas of the hip or the sacroiliac joint, but we're looking for pain reproduction or symptom reproduction right on the lateral aspect of that greater trochanter. So absolutely this test will tell you lots of information, but specifically we are looking for pain reproduction. So these are all aggravating tests to provoke that specific lateral hip pain. And that's absolutely key when we're doing the diagnostic special tests.
Yeah, absolutely. And I suppose just another point on that, Charlotte, is so if somebody reports pain with Faber, that their pain is anteriorly or in the groin, it's actually not telling you any information in terms of trying to rule in GTPS. So we really do need the patient to report the pain as being lateral, as Charlotte said.
All right, moving on to our next test now. We have resisted hip abduction, so abduction. So you're asking the patient to resist into that hip abducted position. And again, we're looking for reproduction of pain over the greater trochanter.